Very good. Wonderful. So there we are. Hopefully you should be able to see the slides very soon. Okay, here we go. Wonderful. So these are my disclosures. What has changed in our understanding of obesity is the following. That we all know that in the last 100 years at least, our environment has changed. And that's why the distribution of body mass index in the population, we all know, has shifted to the right. So we are all a bit heavier than what we would be 100 years ago. But what is really important to appreciate is that if you stop comparing those two different points in time, you just stay in 2023, when we're all surrounded by McDonald's and food which is widely available, cheap and tasty. Of course, there are people that develop obesity. That makes a lot of sense, but there are people also of normal weight and people of normal weight, of low weight. And it is actually surprising to me as to why we're not all are not living with obesity. So within the same environment, we cannot blame the environment anymore. It has to be something else that decides where we are in this distribution of body mass index. And the answer to that question is that our genetics and our biology makeup decides up to 70% of where we are going to be in this distribution. 70% of where we lie is determined by our biology, which is a very big number. So where does this 70% of biology work? Unsurprisingly, it works in the areas of the brain, like here, the hypothalamus and the brainstem. These are the two areas that control our hunger and our fullness. And the gene abnormalities that contribute to obesity disrupt the neural signaling in these areas to cause the symptoms of obesity. The symptoms of obesity being high hunger and low fullness. So what we now understand is that obesity is a disease, and we now understand that the organ that is responsible for the disease of obesity is the brain, and in particular, the areas of the brain that control our appetite and our energy expenditure as well. And that's why I like to provoke people by saying that obesity is not a metabolic disease, but obesity is a neurological disease because it clearly affects the neural cells of the brain, central nervous system, but it has got metabolic consequences. Therefore, for any of our treatments to work, it doesn't matter what the treatment is. It can be a nutritional therapy, a physical activity therapy, pharmacotherapy, or surgery. It has to work like any other disease in medicine on the organ that causes the problem and causes the disease. So if these treatments address the abnormal signaling in these cells in the hypothalamus and the brainstem to reverse the symptoms of obesity, i.e. increase hunger and increase satiety and decrease hunger, this is the only way that this intervention is going to work. Anything else, like eating less and moving more, which what we have been telling patients for the last 50 years, it is not smart enough for this very sophisticated system. The other factor that we need to appreciate when we are treating obesity is that there is a very large heterogeneity of treatment. And this is a beautiful slide for one of the best reviews I've read this year from the Lancet on all the treatments for obesity, where you're going to see that an example of the response to a lifestyle intervention. This can be, for example, a low glycemic index diet, a high protein diet. And you'll see that this will be the average here, which will be a 5% weight loss. But there are a small proportion of people who do incredibly well, and they lose 20 or 30% of their body weight with that lifestyle intervention. Of course, this is a small number. We need to appreciate it is there. On the other hand, surgery, this is the heterogeneity of response to surgery. And we do know that the mean weight loss is about 25 to 30% after gastric bypass or sleeve gastrectomy. However, we also appreciate it that a small proportion of our patients will not lose weight or even put on weight, even though they've had the best treatment for obesity. And at this point in time, we are not able to see a patient at baseline and predict where they will fall in any of those Gaussian distribution curves. These are some of the curves that we're going to talk about in a second because they refer to the responses to medications. So, an additional factor in our decision making is this, which is that depending on the person's not only BMI, but the person's obesity associated complications, we can make some decisions about treatment. So if someone has obesity and prediabetes, a 5% weight loss will be enough to improve the prediabetes part of their complications. However, if the person sitting in front of us has got obesity with heart failure, for example, or established cardiovascular disease, then our target weight loss in order to improve their specific obesity-related complications needs to be in double digits and probably more than 15%. Now, the reason why I'm talking to you about medications throughout our time today is because we finally have got safe and effective medications. And the reason why this has happened is because we have finally understood more about the gut, which is the largest endocrine organ in the body, and the fact that it produces satiety hormones like hormones that you would have heard about in diabetes, for example, GLP-1 or PYY or oxyntomodulin. And these hormones act as satiety hormones in exactly the same areas of the brain that I told you about earlier on. So people feel less hungry, more full, they eat less food than what they're eating, and that's what causes the weight loss. And because our medications are analogs, which means synthetic forms of these native hormones, that's why we think that they are proving to be so safe. This is a slide that shows you what we have been able to achieve with pharmacotherapy over decades, which has been very little, about 5% or so. And when we did have some more successes, that was followed by failure because of the safety drawbacks of all of these medications. However, you see that since 2015 onwards, when we started having medications launched, we are able to do two things. Number one, give them to our patients with confidence because of their safety profile. And number two, we're seeing that their efficacy is rising exponentially, so that by 2025, 2026, we will be able to achieve the same weight loss as bariatric surgery with medical treatments. So I'll run you through some of the best data for these medications to bring you up to date. This is now an old study of the first randomized controlled clinical trial of liraglutide, which is a GLP-1 receptor agonist you probably recognize for diabetes. And what you'll see is that liraglutide at a high dose of 3 milligrams causes a weight loss of about 8% at 1 year. And over 3 years, that weight loss is approximately 6%. And this is the same slide shown in slightly different ways. The 8% weight loss is the mean response to the medication. And remember always about the heterogeneity. What it means is that 63.2% of people in this trial will lose more than 5% of their body weight, i.e. they will be good responders to the medication, whereas at the same time, this also tells us that 37% of people will not respond to the medication. We need to be able to appreciate that, accept it, and if people do not respond to the medication, we need to stop the treatment and offer them something else. This is one of the trials that have convinced authorities both in the United Kingdom and in Ireland to adopt Saxenda for obesity, and that is on cost effectiveness grounds, because it appears that this reduction that you are seeing here in the development of obesity in people who have got pre-diabetes is what makes this medication not only effective for the individual, but cost effective for the healthcare system as well. Therefore, I'm just showing you the nice guidance here, but which is very, very similar to the guidance in Ireland. It is a very specific group of people that can have Saxenda in the public healthcare system. This is the BMI cutoff. They need to have pre-diabetes, as we have just said. They need to have evidence of higher risk for cardiovascular disease, and it normally needs to be prescribed in secondary care in the UK, but I understand that in Ireland it can be prescribed in primary care as well. Anyway, so the issue here is that a small proportion of our patients are going to benefit from this treatment, but it is still a good start. Now, there are no drugs that work that I know of that do not have side effects. And the common side effects with this group of drugs in general can be seen here. The common ones being nausea, diarrhea, constipation, or vomiting, so gastrointestinal side effects. Now, the good news is that these side effects will peak during the first few weeks of treatment, but then they will come down, and then most of the patients will be able to tolerate them long term. Here you see some of the timelines about the resolution of nausea in those people. It will be 5 to 10% of people that cannot have these medications because of tolerance issues. The vast majority will be able to tolerate them very well. In terms of long-term consequences, the two worst-case scenarios are that, which are rare, by the way, is that someone can develop cholecystitis or pancreatitis, which are in their majority reversible. What is coming our way? This medication has just been released in the UK 2 months ago on the 4th of September, and I understand it is being assessed in Ireland, hopefully for launch, I'm guessing in the new year. That'll be a great thing to have. This is Wegovy, or semaglutide, which is a sister drug to liraglutide. And the difference here is that semaglutide is a once-weekly medication. You may have already got experience by treating people with diabetes with semaglutide, but this is the treatment dose for obesity, which is 2.4 milligrams, which is a high dose. And what you'll see from this step 1 randomized controlled clinical trial is that the weight loss at 1 year with semaglutide is approximately 16%, i.e. double what can be achieved with Saxenda. And we know that a lot of this weight is maintained at 2 years. And what we also know is this piece of information here, which is very exciting. So what you'll see here is that these are the same. This is the same trial, but expressed as categorical weight losses, or more than 5, more than 10, and more than 20% weight loss. And 1 in 3 of your patients on Wegovy will lose more than 20% of their body weight. So now what we can achieve with medications is getting serious, and it is very much entering the range of response that we are seeing with bariatric surgery, and more data to come on that in a second. So this is the nice guidance on Wegovy, and I have a feeling that the guidance from the Irish authorities is going to be very similar, which is that people with a body mass index of over 35 with at least one obesity-related complication, or people who qualify for referral to a weight management service, even with a body mass index of 30 to 35, would be eligible for the drug. What does that mean now? In the UK, this means that millions of people are eligible for the medication. The funders, after this approval from NICE, have done their mathematics. They have seen what the bill looks like, and they have said, thank you very much. Don't call us, we will call you. That's because it is very, very expensive. So now we are making a lot of attempts, many attempts, and are spending a lot of our time trying to convince the funders that they have to provide this service. I have told you good things about these medications and weight loss, and I don't have enough time to tell you also the other beneficial effects on the individual in terms of the metabolic and functional complications of obesity. But it is really important to spend a small amount of time on this slide, which is the SELECT trial. And in the SELECT trial, we recruited people across the world who had obesity and cardiovascular disease established and gave them semaglutide versus placebo at a dose of 2.4 milligrams. And I am very excited to say that the results of the trial will be published tomorrow. But what we know from the headline results is that this medication is not anymore a weight loss medication or cosmetic, as some people might call it, but it is a medication that makes people live longer because it reduces the risk of death or recurrence of any of those cardiovascular events by approximately 20%. What else is available in Ireland for obesity? This is the other medication which is available in the market, not available in the healthcare service. It's Mysimba, perfectly safe, perfectly licensed and evidence-based. It's a tablet that contains these two medications that you may recognize, bupropion and naltrexone. And interestingly, again, these medications work exactly where the problem is. And what they do is they stimulate these satiety neurons in the brain in the areas we talked about to decrease appetite and also to decrease cravings, and evidence also, and there's also evidence that they also decrease binge eating episodes. And these are some of the nice trials that have been done on Mysimba, and they demonstrate an 8% weight loss if you focus on this randomized trial here, which is the same as Saxenda. So again, this is an option which is available to patients, and it can be first line or second line. Now we're getting to bigger guns as we're moving through the talk, and tirzepatide has just been approved by the MHRA, the pharmaceutical authorities in the UK. That happened only yesterday, and I expect that will be approved very, very soon in Ireland as well. Now, tirzepatide is a very clever molecule because it contains two gut hormones, two satiety hormones, and two hormones that increase insulin in order to improve diabetes. Here, what I'm doing is I'm showing you the evidence of tirzepatide for weight loss in particular. And you see here what with the highest dose, if you follow this line, people will lose 22% on average from their starting body weight at 72 weeks of treatment. So we have moved from 8 to 16 to an average of 22% of weight loss. And if you scroll your eyes here, you see that 1 in 3 of patients treated with a high dose of tirzepatide will lose more than 25% of their body weight. So now this is not just having effects on metabolic outcomes, but it is probably going to start having effects on functional outcomes and complications. And we may see that tirzepatide may also prove to be beneficial to the cardiovascular system when the trial reads out. I suspect that tirzepatide will become available first for diabetes, and it is a very potent medication for diabetes, and then it will get the indication for obesity based on the studies that I'm showing you here. What is now entering phase 3 studies is this, which is the retatrutide, and it is an analog of 3 hormones in the same medication. Super exciting developments from a pharmacological perspective, and the reductions in the reductions in food intake and body weight that we see are truly impressive. And from this phase 2 study, you're seeing that the average weight loss with a high dose of this medication is 25% or so. Therefore, rapid increases in what we can achieve. I'm not going to spend time on setmelanotide, which is a treatment for rare forms of genetic obesity, but I'm going to close because I would like people to ask questions. And I'm going to say that in addition to everything else that you are doing to prevent obesity and everything else that you are trying to treat obesity, consider adding biological treatments to support your patients, because we finally have them. They are safe and effective. The progress is extremely rapid. We do need to know about long-term safety of these medications. However, from our experience from diabetes, we know that they have stood the test of time. And they are expensive without a doubt. But with time, competition, and patents going, they will become cheaper. And then they will be more widely available for a large proportion of our patients. So what I'm going to do is I'm going to now stop sharing, and I will get back to the screen, hopefully. Yep. And then I would be very keen to take some of your questions.
So thank you very much for that really interesting talk. I think it's insightful to hear about the genetic component to obesity, because I think throughout my medical training, there was a different, and well, even my upbringing with family members, it was very much, you know, do this, do that, eat this, do that, and why aren't we losing weight? So really interesting to see why people aren't losing weight with those old-fashioned remedies. So now I open the floor to questions. Is there anybody who has any questions for Professor Miras? Just looking out onto a sea of faces here. I have a question from Dr. Hodgson. We're just waiting for his microphone so you can hear him.
Thank you. It's on, yeah. Thank you. I saw the guidelines for 2 years treatments. What happens when you stop in 2 years? Is the weight stay off, or does it go rapidly back on again?
Thanks for asking that question. When you take antihypertensives and they bring the blood pressure down, and the medication is working, you don't stop them, because you know that when you stop them, the blood pressure will go up. We need to start thinking in the same way about obesity, because as you are suggesting, exactly that will happen. When you stop the medications, the weight will go back up and you would have lost what you have achieved. So these are cost effectiveness decisions that have been made on the available data. This 2-year rule doesn't make clinical sense. So that's why NICE has, in the small letters below the guidance, says that some patients will need to be retreated. So I think that these are kind of teething problems that we're having in the field, because what we're doing is relatively new, and these 2-year rules will disappear.
Thank you very much. Is there any other questions from the floor? There's another question. We're just waiting for the mic to travel.
I would like to know, like, because you're doing like a long-term treatment with a drug, which type of analysis or exams you need to do, like to see if your system is okay, if you're having some side effects, or what the type of following up you need to do when you do this type of long-term treatment with this type of medicines?
That's a very good question, and I will tell you that the key follow-up is clinical in the first 4 months. So what we always do is we start the treatment, and then we wait for 4 months before we start deciding whether the treatment is working or not for the patient in front of us. If people have lost more than 5% of their body weight at 4 months, they need to continue, as we said earlier on, taking the medication long term. Now, beyond that, beyond the 4 months, the monitoring of these patients can be very, very light. What that means is that you can follow people up every 6 months. When people are stable, I follow them up every year even, just to make sure that everything is going well. In terms of monitoring, the bulk of the side effects, if they do take place, will be there in the first 4 months, and then they will settle. It's unlikely that suddenly, after, say, 2 years of treatment, someone will start having nausea. Unlikely. But they can, at any time during their treatment, develop pancreatitis or cholecystitis, and we need to accept a small risk about that. With regards to biochemical monitoring, there is zero biochemical monitoring that needs to be done for safety. However, you can do biochemical monitoring for efficacy. So you may want to see the effect on HbA1c or the effect of lipids, but no safety monitoring needed.
Thank you very much. There's another question from the back of the room. This may be our last question. I'm itching to ask a question myself, but we'll see.
Hi, can I just ask how you integrate exercise and diet advice in these studies, or in general, as in, do people think, well, I'm taking the drugs, I don't need to do anything myself, like I can now eat what I want and not have to do anything? Or how is that? Is it controlled for? Or I love the idea that maybe drugs might help out, but I also still feel there's obviously the people maybe still need to be aware of their responsibility as a little bit in terms of not just eating or not doing anything? Or how is that controlled?
Okay. Yeah, I wouldn't call it responsibility, but I will answer
Yes,
the question, which is a good question, which is in all of those trials, people receive a like kind of low intensity behavioral intervention, which involves pretty basic advice, both in terms of eating behaviors, in terms of physical activity, and some psychological support. And that is why you're seeing an effect on the placebo group as well. It shows that these things do work. And you need to be, as I said in my last slide, is you don't do just medications, but you combine the medications with the behavioral modification that would benefit the patient in front of us, depending on what they need. Usually what people need is to be coached on what to eat in terms of quality. So the medication will make them eat less of whatever food they're eating. Where I find the role of the nutritionist and dietitian important is in telling them how to increase the quality of the food that they are eating. In addition to that, you continue with the physical activity interventions because we know that they will be able to help sustain the weight loss, and they will be able to make the person metabolically and cardiovascularly more healthy. And in addition to that, we need to be offering psychological support, but only to those who need it, because not everyone with obesity needs psychological support. And the psychological support would be to deal with the psychological aspects of eating behavior. Again, the aim being to enhance the effects of the medication. But let me just say, and to make it clear, that even if you don't do these things, the medication will still work. But if you add the medication to those interventions, you're going to get a better effect.
Thank you very much. And are there any more questions from the floor? No, it would appear not. And it appears we've lost Dr. Miras, have we?
No,
Oh,
I'm still
you're
here.
We lost your picture, but I wasn't sure.
Well,
whether
you're not missing much.
I've not really got time, and I meant to be keeping to time. Can I ask a question that you could answer very briefly? Is
Yes.
that you talked about it being satiety and hunger as almost two different aspects of the sort of components of obesity or risk factors for obesity. These drugs, do they hit both pathways, or do they hit one specific?
Okay, that's a good question. So high hunger
You've only
and
got a
low.
minute, though.
Yeah, that's fine. High hunger and low fullness are the symptoms of obesity.
Okay.
And what these treatments do is they directly address the symptoms. In particular, what they do is they assess satiety. It is fullness that they mostly address. To a certain degree, hunger as well. To a certain degree, cravings and the rewarding value of food. But the dominant mechanism is an increase in satiety.
Brilliant. Thank you so much. And we really appreciate you coming online between clinics. Thank you so much.